And I think we will get started. I know that we still have a number of people who will be joining us, but I will get us started today. So as you see, we're going to be talking about simplified prior authorization today and some new resources and solutions that are available in the marketplace. Once again, my name is Denise Balch, and I'd like to thank you for joining us today. This is the next in our series of webinars. The last ones were held in the spring-summer time frame. I will be your moderator and your chair today, and I'm also going to be one of your presenters, which I don't do too often. Before we get started, I'd like to thank our sponsors for making this initiative possible. Now, this initiative has been going on for a few years, so we did have other sponsors involved at the very beginning, but for those sponsors that are with us as part of what we're going to be speaking about today, I'd like to thank our platinum sponsor, Amgen Canada, and our gold sponsors, Gilead and Lilly, and our silver sponsor, AstraZeneca. So thanks very much for making what we're going to be discussing today, at least from the website perspective, possible. I'd like to also thank our advisory board panel, and as well my internal team. And you'll see that the website we're going to be looking at today is fairly complex. And my team's been working hard. So Nathan Smolsky, my IT manager, Beck Westcott, our web developer and accessibility consultant, and Nathan does some of that web development as well. And Radia Karadia, who's a reimbursement educator and researcher. She's actually a co-op student and a health sciences student at Laurier University in her final year. You will all have received an email with the agenda for today. We're going to be doing some polling in just a moment, but I would like to just remind you that if you do have any questions, please put them into the chat box, and I will be monitoring that, and so will Nathan. For those of you that are licensed that need CE credits, please complete the evaluation, which will pop up at the end of today's session. And if you complete that evaluation, then we will know that you're eligible to receive CE credits because you've been with us for the duration of the event today. So I'm just going to move forward my slide deck by one. Let's make sure that we can get that. Yep, there we go. So we've got the agenda. Just a sec. So I'm up first. I'll be talking to you about our new website for prior authorization stakeholders. Then we have Rami Al-Kholi, who's with OKRX, and he'll be speaking about their electronic prior authorization solution. And then we'll be moving into our panel discussion. Each of our 5 panelists are experts in their field. They will be speaking for 5 minutes after I introduce each of them individually, really as to what their role is in prior authorization and specialty drugs. And then we will open up our panel discussion. I have some prearranged questions, but we'll also be taking questions from the audience. If there are any points of clarification during my presentation or Rami's presentation, by all means, please don't hesitate to write down your questions or your requests in the chat box, like I mentioned. So we have polling. So Nathan, those of you who are with us regularly will know that I like polling questions, and it helps us understand who our audience is and a little bit about what your perspectives are before we get started with presentations. So Nathan, if you could please bring up our polling. We do have a few questions for you today. So please, you can see the scroll bar on the right-hand side. So if you want to just please complete, and there are 5 questions to tell us what industry sector that you actually represent, what percentage of your time is spent on prior authorization, to what extent you think there needs to be more resources about prior auth and assistance in understanding that process. Based on your experiences with prior authorization, if any, what best reflects your experience of the current process, and why you registered for today's session. What's your motivation? So if you could complete that, and when we've got a reasonable number of folks who've participated in the polling, and for those few people that are just joining us now, we haven't quite started yet with our presentations. We're just going to complete the polling, and then I'll start with the first presentation. So we'll give you a few minutes. If you could complete that, it's very helpful to us in really understanding who's on the line today. So right now, it looks like we have mostly a mix of advisors and insurers, which is great. Oh, the numbers are coming in. That's great. Thank you very much, everybody. I'll just give it one more minute and then we will have a look at our results so that we can keep to our agenda time, get to the good stuff. If you do have any difficulties with your connection, you can text or email Nathan. I think that was covered off in the introductory email that you would have received this morning. Okay, so I think we're going to leave it there. We're going to end our poll in 3, 2, 1. And I've got somebody who's raised a hand, so I'm going to look at that in a couple of minutes. Okay, so we're going to end our poll and look at the results. I'm going to share those results. And for some reason, I can't see the results. Oh yeah, maybe I can. Here we go. So we have 32% of you are advisors and 23% represent insurance companies. We've got a 30% other, so we obviously missed out on one of the groups that we thought would be represented. So thanks for completing that. What percentage of your time is spent on prior authorization? So most of you have very little exposure to prior authorization, or very little time is spent on prior authorization. To what extent do you think there needs to be more resources about prior auth and assistance in understanding the process? We've got 69% of you think that there should be more resources. Well, we're going to help you out with that today. And 20% say they just don't have enough experience to say. Based on your experiences with prior authorization, if you have any, what best reflects your experience of the current process? So 62% tell us it's not fine and there needs to be some improvement. 33% say they don't really have enough experience to know or to say, and 5% think it's fine. And our last question, why did you register for today's session? We have 55% of you say that they're interested in opportunities to improve the current prior authorization process, that 52% want to understand more about the process, 43% are interested in the new online resource, and 45% want to learn more about electronic prior authorization, and over half of you want to hear the opinion of experts in the industry about prior authorization and the future of, well, the future of, I can't remember exactly what I asked, but we will be sending out the results for that anyway. So I'm going to stop sharing. And as was pointed out to me, my screen is already being shared. So I will get started. So I like to start off with the definition so that we all are on the same page. I'm pretty sure that most of us are on the same page, but let's just review this. So according to my definition, the definition that I've been using on this particular initiative is that prior authorization is a process by which private payers, that being insurers or pharmacy benefit managers, reimbursed a prescribed medication on the condition of satisfactory medical evidence from both a patient and their physician, according to the criteria that's established by payers. So that's the basis on which we're going to be discussing prior authorization today. Now, I've been involved in prior authorization for a long time, but I haven't been out there in the trenches looking at prior authorization claims and adjudicating claims or designing systems to adjudicate claims. Rather, it started in 2020, just at the beginning of the pandemic, when I worked with Bev Hertzig from the Pangea Group to do a research paper, a white paper on prior authorization. And we talked to a number of different stakeholders in the process. And the summary, a very quick summary of a very long report of our results, is that the current prior authorization process was really seen as inefficient, costly and time consuming, and somewhat frustrating, particularly for folks like patients, patient support programs, drug access navigators, and of course, physicians. So from that, we gleaned that there were opportunities to improve the process, and those folks that we spoke to provided us with some suggestions. We also knew that in Ontario, and I know that also in BC too, I believe, has an active system that is a version of an electronic prior authorization process where I believe SADI now in Ontario, I think pretty much all claims for prior authorization need to be completed and submitted online, and the responses are provided electronically online too. So that was really kind of a flag for us to say, okay, this is possible, it is being done, and by the public sector of all people. So in 2021, we gathered additional support, and I should say that the initial support for the white paper and the microsite that was developed was from both Amgen and then later Gilead. And in 2021, a number of stakeholders supported additional field research that Bev Herzig and I conducted, the development of that information microsite, more advocacy for improvements in the prior authorization process, and moving towards an electronic prior authorization process, and really to provide, additional expertise. Like we were looking to additional expertise to expand our knowledge of prior authorization, to really provide better education and advocacy on how the process could be improved. In 2022, we have really spent our time in really two specific areas. One was to develop a new and expanded stakeholder website, because it was very clear that there was a need and a demand for a more comprehensive website than the initial microsite that was developed. A site that would provide a number of resources for a number of PA stakeholders. And so that's something that we're going to be looking at today. We also wanted to spend time to work with providers who were able to really move the prior authorization process forward. And our job was to also advocate and continue to educate about the need for improvements in prior authorization. So as I mentioned earlier, we held 3 webinars earlier in 2022. Most of you will probably have seen our blogs and podcasts because you are on our mailing list. And so we've been very busy kind of keeping that message going about the need for improvements. And so what we're going to be looking at from my perspective today is we're going to spend, I guess, the next kind of 15 minutes looking at the actual website itself. Before we click on the link and hopefully magic happens and we can see the website, I just wanted to explain to you the areas of the website because it is a fairly complex site. So there were 3 real objectives which our advisory board and myself worked on in really the winter and early spring of 2022. And that was that we wanted to provide a platform for further advocacy and information, so that we would get the word out there about, filling the gaps in knowledge really about prior authorization and the need to improve the process and move forward. The other was an education and really providing sort of a Q&A sort of responses to frequently asked questions. So an education resource, but from the perspective of each stakeholder, so that each stakeholder would have a place on the website that was kind of speaking their language. So that we weren't, speaking to physicians like we would speak to, say, patients who don't have the medical background or the knowledge and experience with prior authorization that physicians would have. We also wanted to be sort of a landing ground, a ground zero for resources about prior authorization, and also other stakeholders in the process. So whether it would be drug access navigators that help mostly cancer patients with their claims during treatment, or whether it would be, say, patient groups, or whether it be insurers, so that you don't have to keep Googling insurance companies if you're a physician. They can actually find insurance companies and their prior auth pages all in one spot, and provide access to other websites that also facilitated prior authorization. I'll just go through what we want to do in 2023. So just keep this in mind as we're going through the website. The site is really not a fait accompli. So we're not looking at it as a stagnant website. We also want to, in 2023, build on the initial site that we're launching today, to continue that advocacy and information role in the marketplace and really create more buy-in amongst stakeholders for moving forward with an improved process for prior authorization. We also want to explore creating an industry survey, perhaps an annual or maybe one that takes place every 2 years, to really take the temperature of prior authorization, reach out with a quantitative survey to prior authorization stakeholders, and really provide some immediate kind of feedback, annual or biannual feedback to stakeholders in the process, anybody that has an interest in prior authorization, so that we can get a better sort of regular temperature about the environment. And then the last thing is, what we know about prior authorization is every insurer or payer, pharmacy benefit manager, has their own kind of internal best practices. And what we thought would be valuable to stakeholders is to have an outside resource for evaluating best practices. So saying, well, how long should a claim take? And, how easy are forms to access? And so that's something that we're going to be exploring in 2023 as well. Now, all this costs money, of course, because we have a team working on this. And so we're obviously open to opportunities to partner and secure not only human resources and expertise, but also financial as well. And so we do have a sponsorship package that is available if any of the organizations that are represented on the line are interested in seeing that. Now, before I switch over to the website, I noticed that we do have a couple of things going on in the chat box. So you'll excuse me, since I'm operating as presenter and chair, if I have a quick look at our chat box and see if there's anything I need to pay attention to, anything I'm doing that I shouldn't be doing. The white paper should be on that Simplify Prior Auth site. And I noticed that one of our attendees are saying that the current link isn't leading to the white paper. So Nathan, if you can mark that down, and we will make sure that that gets fixed so that you can find the white paper on, yep, it is on the, okay, it is working. She's got it. Okay, so I'm just reading this through, just bear with me. Okay, great. So Nathan has responded to that. Okay, so that's it. There was nothing that I needed to take care of. Thanks, Nathan, for looking after that. And we'll now go to the site. Now let's see if this link works, but if it doesn't, I have the site open anyway on my computer. So let's just see if this works. It's always fun doing these. I actually have some screenshots in case we have any other issues. Okay, so I'm going to stop sharing for just one moment. Just bear with me, and I'm going to do this a different way. 2 seconds. All right, it's all happening. Hang on. Here we go. Okay, I'm going to share my screen again. The magic of technology when it works, you can sort of breathe a sigh of relief, you know what I mean? All right. I noticed that just flipping over to my next page of notes, that one of the things that I didn't do was introduce myself properly. Sorry, there was another quick note. And I think most of you know me, so I don't want to kind of belabor it. It's always awkward giving your own bio, but I'll just give you a little bit of my background, just so you know, kind of like, who is this woman and why does she think she knows anything about prior authorization? Well, I have been an employee benefits professional for many, many years. I hate to even admit how many years, but it's definitely just shy of 40 and well over 30. I have founded 2 benefits education series, one of which was 30 years ago, and that's the Benefits Breakfast Club, which I continue to manage following its recent sale to Crosslinks Consulting. And I continue to provide consulting services on the benefits and private healthcare sector to industry stakeholders. This is one example, the Simply Prior Authorization Initiative. So Connects Health will still be up and running, which is my consulting end of my operations. And I'll be still the project manager for Simplify Prior Auth. So my work extends on the consulting side from industry research reports, white papers, strategic consulting, crazily enough, web development, as you'll see here, which we'll be discussing today, as well as social media campaigns. So sort of your catch-all in terms of the private healthcare sector. So let's take a look at this site. This is our homepage. You can always get to the homepage by linking with our logo. And the site is available en français as well. And thankfully, to all of the people that are primarily French speaking on the call today, luckily you don't have to rely on me for translation. So that was professionally translated. So this is our homepage. There are the links that you find across the top. Many of these are also available on the homepage. We want it to be a complex site, but something that's simple to navigate. So in terms of a perspective on prior authorization, we have links to pages that address a prior authorization from all of these stakeholders' perspectives. So from the patient or patient group, physician, prescriber, and pharmacist, the plan sponsor or advisor, the patient support program, or the insurer or pharmacy benefits manager. So you can click on any of these, and I'll do that in a few minutes, and we'll give you an example of some of those pages. We also have a section on electronic prior authorization, so you can see the quickie explanation here, and then you can see that it's also available at the top, and there are several sections to the EPA section of this website. You can also contact us. I think that phone link goes to my cell phone by email. Or you can write to us, which I'm not sure that many people would do that these days. This is the quick link to some of our blogs and podcasts. They are only in English, I'm sorry, but you can tell whether they're a blog or podcast by the icon to the right-hand side of the heading, and you can tell when they were first released or published by the date at the top. We actually just had one of our panelists was on a podcast with me earlier, a couple of weeks ago. I was going to say earlier this year, but that's not that long ago. And that podcast was released just last week. And of course, upcoming events, and this session is there. And then we have a contact us form, and you can also sign up for invites to future sessions, webinars, blogs, and podcasts. Our financial sponsors are recognized, and of course, our advisory board as well. I'll just take you through the tabs. Again, all of the information on the homepage is grounded in these tabs. So you can navigate the whole site through these tabs and return to the homepage by just clicking on the SPA logo. So when we have news, you can see the drop down. You can find links to the events and webinars, blogs, podcasts, articles, and the white paper. So if we look at, say, let's look at podcasts, you will see that the most recent podcast that was also on the homepage, plus a history of our other podcasts. So you can listen to those or download those at your leisure. And same thing with the blogs, articles, and then I know we had a note in the chat box about the white paper. And so the original white paper, there's a summary, and then there's the full white paper. So you just click on that box. And of course, if you have any questions or comments, you can click on the contact us link. Now, this site is brand new. So there's bound to be one or two little things that we may have missed, although we've been working very hard on it. So if you are going through it in the next week or so, or anytime in the future, and you notice something that's a little bit out of date or off, or something's not quite working, please do let us know, and we'd be happy to hear from you so that we can correct it. Okay. The IM is where I think it gets pretty exciting. So when we look at a patient or a patient group, and we'll just click through this, we have broken that down into several sections to make it really into bite-sized pieces, and all of the IMA sections are in bite-sized pieces. Now, the whole site complies with new accessibility standards, and so do the PDFs. They are accessible PDFs. So all of the information that is contained under each link is also available in a PDF format. Let's go back. And it's also available on video. And so I'm going to show you the first video. Please let me know in the chat box if you can't hear it.
Welcome to the Simplify Prior Authorization Doodle video series. In this series, we will be providing some important information related to prior authorization for patients, including group benefits basics, specialty drugs, why prior authorization is used, what the claims process looks like, and how to manage denied claims. In this video, we will be going over group benefits basics and your coverage for prescription drugs. If you're a full-time permanent employee, a member of a union, an association, or student group, then it's likely that you have access to group insurance coverage for a plan offered by your employer, union trustees, association, or student group. Some group insurance plans have comprehensive coverage that includes life, disability, dental, and health, which includes prescription drugs. Other plans, particularly plans.
So I'm going to stop it there. Hopefully you were able to see and hear that video, because I know that I want to make sure that Rami has enough time for his presentation. This is also available in French, so the accessible PDFs and the videos are available in French. So they are available to patients, and you can certainly, if you're an advisor or plan sponsor, you can certainly provide the simplify priorauth.ca link to your clients, and they can provide this link to their employees as well. If they do have specialty drugs, they may find this information on the site useful. We look at what a specialty drug actually is, why not all drugs can be provided directly by your community pharmacy, and why there's a special process for some drugs. And also, we also talk about denials and what happens if your claim is actually denied, what are some of the reasons why it's denied, and what the next steps are in that process if you receive a denial. And so, as I said, we have messaging that's targeted to each of these groups, including insurers and pharmacy benefit managers. We didn't want to leave that very important group out. On the electronic prior authorization page, we talk about the prior authorization landscape as it is right now. We talk about what electronic prior authorization actually is, why change hasn't happened yet, and what some of the future is for prior authorization. We're confident, based on how the market has been progressing in the last few years since the original white paper, that things will be changing soon, and that patients and pharmacists and other stakeholders can look forward to the first generation anyway of an electronic prior authorization process, where claims are completed online and submitted to payers for review. The other page of the site is a resource page. And so what we've tried to do is provide as many resources as we could think of, and we're certainly happy to add more resources and links to those resources. So this particular one is a tool that's been developed by the Canadian Skin Patient Alliance that can be used by patients, or really anyone who have received a prescription or know of a prescription and plan to fill it out. It's an interactive drug coverage finder to help patients determine if they have coverage and where they might have coverage. So there's a direct link to the website, and there's an email. There is actually a PDF about denial, or there's actually an article about denials of claims from the Canadian Breast Cancer Network. Drug Access Canada, which some of you might be familiar with, is a website that has information and claim forms available directly on the site. Also, the Drug Access Navigator Association and the National Association and the regional associations are all linked here. We explain what a drug identification number is. There are links to all of the insurers' prior authorization pages. There are a number of patient groups. This list is not every single patient group. It's just every single one we could think of or find. So certainly if your patient group isn't represented, or you know of a patient group that should be represented here, then by all means, please let us know. Also, the key patient support providers are listed here with a link. Also, we have a downloadable PDF just talking about prior authorization stakeholders in general, provincial drug coverage downloadable PDF that we've created, and links to specialty pharmacies as well. So that's all we have on the resources page right now, but we certainly are happy to add more, and we will be keeping this site up to date regularly. And then the last page that I'd like to show you, I'm not going to show you the French version just in terms of time, but it is fully operational right now, is a glossary. So you can look at all, or if you say wanted to look at, maybe look up something beginning with P, so patient group, or something like that. There you go. So I just thought of patient group, clicked P, and then everything beginning with P is listed here, and we've provided a definition so that any stakeholder, no matter what their level of knowledge is, they don't have to be overwhelmed by jargon. They can look up whatever term they're not quite familiar with, and it should be in this glossary. So that's really all I'm going to say about the prior authorization website right now. Please take some time. We did send you, no, we actually are going to send you the link. That's going to be in our post-session email to you. You should get that later on this afternoon before we collapse from exhaustion from all the work that we've done getting the website ready for today. So you'll get that link, and you'll get a link to my presentation as well. And there's some screenshots in my presentation. I did that just in case we couldn't get live onto the website. So I hope that you like what you've seen. As I said, play around with it. Let us know if we should have something that isn't there. And if you are fluently French, if you see anything that's not quite right, everything should be okay on the French side. But if you see anything that's not quite right, please do let us know. And we look forward to your feedback and suggestions on, how we can make this a better tool for the industry, and really kind of the benchmark platform for prior authorization information in Canada. So with that, I'm going to just have a quick look at the chat box. And okay, there are some things that I'm going to address later on. There's some very specific things about products that I can't actually answer, but I can get back to you on, but I may still not be able to answer. There's some questions about definitions on biologics, and there is information on what the difference is between a biologic and biosimilar, as well as name and generic brand drugs. So that's in the patient section. And then there's a note for Nathan there. So I'm going to leave it there and ask Rami to join us. Rami, I'm sorry I stole 5 minutes of your time. I hope you'll forgive me. Rami is a licensed pharmacist in Ontario who completed his Doctor of Pharmacy at the Albany College of Pharmacy and Health Sciences in the US. He is the Chief Commercial Officer with OKRX. He has built his understanding of healthcare through roles in both Canada and the US that have developed medical information, pharma product marketing, brand development, regulatory intelligence, and a whole bunch of other things connected with patient support programs, pharmacy operations, and digital health. So Rami, I know you're going to talk us through, every time I see your platform. It's changed, it's gotten better, you've made improvements. So I'm really looking forward to hearing what you have to say today. So thanks very much for being with us.
Thank you, Denise. I will start now by sharing screen. Just let me know when that comes through for you.
Second. Yep, we're good.
Okay, awesome. So thanks, Denise, again for the introduction and for the website. As you can all see, there's a lot of resources on the Simplified Prior Authorization website. It gives a great background on all of the different stakeholders and their challenges related to Simplified Prior Authorization. And once you get through that, you'll have a clear understanding that this is a challenge. So what I want to focus on today is how are we going to actually move forward on this challenge? What steps can we take? And how are we really going to simplify that prior authorization process? And so before we go any further, we have to make sure that we have a baseline and an understanding of what the challenge is here. And navigating drug prior authorizations has many challenges. So I'm going to highlight a few of them before we dive into the solutions here. So we take Homer Simpson, who's recently visited his oncologist, and this could be rheumatologist, dermatologist, many other disease states that are affected through this PA process. And they've decided to prescribe Homer a combination therapy. And this situation would be challenging even if it was a monotherapy. But here we have a dual therapy for oncology. And so Dr. Hibbert's team, and this could be comprised of drug navigators, pharmacists, programs, must now start this for Homer and this process. So the first challenge they're going to have is finding the proper forms. Every insurer has a different form. These forms change frequently. And the graph below here proves that because we in our library had all of the Etanercept prior auth forms. And we found that in the last 12 months, about 25% of them would change within 7 days of release. This could be because of new criteria, new biosimilars. The point being here that it is constantly changing. And so to have an updated library of these forms is critical. It is also critical when you consider how much effort is sometimes put into putting these forms into EMRs for integration. Because once this form changes, you also have to then change the form that you've worked to upload into your EMR. And so sometimes it's also difficult to obtain these forms, different websites, different passwords. Some forms are only available on iPhone. And you also don't know which beneficiaries will need specific forms based on the groups that they are part of. Once you have successfully obtained the form, completing this form is a whole other issue. Yes, again, people put these forms into EMR, you can extract some data, but many of these forms are information isn't just found in the EMRs themselves. They come from a variety of different sources, whether that's patient support program level data on program details, spousal benefits coverage, provincial benefits coverage. Not all of this is found in the EMRs. So you're going to have to inevitably work with other stakeholders to get it collected. And then you're going to have to work with these stakeholders for the third point here to get signatures to complete this form before you can submit it to the insurer. And so once you're ready to send it to the insurer, the second part of this issue happens, which is everything received by these insurers today is currently flattened. And we want to avoid this F word as much as we possibly can, because what happens is insurers put PDFs out into the world. People either fill them traditionally through printing them, scanning them, faxing them, and so forth, or they might, as I mentioned earlier, put them in different CRMs or EMRs so that they can auto-populate. Or once they've auto-populated, they then sign it through digital signature solutions such as DocuSign. Every single one of these is a culprit for what's called flattening. And when you flatten things and try and send it to the payers, this is the difference of what happens. Here on the left is a flattened form. And as you look at the different fields in the form, you'll notice that all of the coding on it is strictly images. Versus a non-flattened form, when you look at the fields on the form, you can see data, so you can extract that data. And this is what will lead to downstream interoperability and the eventual goals of EPA.
Sorry, Rami, I'm just going to ask if you can just go back one slide and just explain what a CRM and an EMR is.
Sure. So a CRM is a customer relationship management system. It's often used by patient support programs, pharmaceutical manufacturers in-house who are managing these programs, and other times any basically CRM system that might house these forms. EMRs are electronic medical records. And there's also EHRs, which are electronic health records, essentially databases for these patients' records, and then many times places where these forms are sometimes created internally so that the forms can sprout from there. But we obviously have to be concerned with the whole end-to-end process here if we're going to go to electronic prior authorization. And so we've discussed flattened versus non-flattened here and how it's critical to keep the data intact within the forms. The other challenge that we have is a recent analysis showed that only 2 of 16 major insurance carriers in Canada had PA forms that they produced, the PDFs that they put out there in the world, that passed the Adobe Accessibility Check and PDF University accessibility checks. So it's also important that as you work to create better systems, you're keeping in mind the accessibility compliances that need to be upheld. And so it's an opportunity for 2 birds with 1 stone, so to speak. And so when we look at considerations for these challenges, now that we understand them well, the first thing we must realize is to address this problem, because there are many forms all across different provinces, across different plans, you need to build them and house them in one centralized ecosystem. And when you do that in one agnostic digital forms engine, it will allow for easy form configuration. It will allow for automated form version management. And what that means is this digital forms engine can track every night through a crawler whether that form has changed from the private payer's website. And so if new criteria is added, a new drug, a new checkbox, the system will automatically flag that the previous version is now outdated and that a new version is available to make it available to everyone in the ecosystem almost simultaneously. The other thing that a digital forms ecosystem can do is allow secure data transfer between all of these systems that need to work as part of the prior authorization process. It will also allow digital fill and sign workflows, which are critical, as you saw from the case of Homer, to getting these forms completed across all of the different systems and stakeholders that need to touch these forms from time to time. And finally, as I mentioned just before, when you build these forms for an ecosystem in one centralized agnostic place, you can also make these PDFs accessible and pass the accessibility compliances. So a big consideration of any of these forms, and once you've created this digitized agnostic central library, is that you need to make it agnostic for any product or condition. You also need to make it agnostic for any plan, whether that's public or private. And the reason you need to do that is exactly the situation we saw here in Ontario with SAIDI, and that we are starting to see in other provinces, which is SAIDI is a great concept, it is a great step forward, but it is only for the EAP form. How pragmatic is it if it's one platform for just one site? Especially as you know that the EAP form, whenever it is needed, may often accompany a Trillium drug application form, a private payer form, a PSP enrollment form, and other such forms. So does it really make sense to continue to make standalone websites for individualized forms and just recycle the silos? And so what you need to do is once you've created that centralized agnostic digital form library, you need to now integrate it with all of the different stakeholders that touch these forms and their systems. So for prescribers, you absolutely need to make these forms play nice with their EMRs. For many times, many people think that the prescriber is the be all end all, but you have to recognize that there are other stakeholders that are assisting this prescriber with the PA forms. They might include pharmacists, so you need to also work with the dispensing systems they use. This might include also PSPs and the CRM systems they use. It might include drug access navigators and people who use standalone websites. So these forms also must play nice with the different websites that might house these forms. And finally, there might be no incentive to link with any of the current stakeholder systems because it might be a long-term process. There is still opportunity to make the PDFs better so that they can work interoperably with this digital forms engine and make life for the insurer downstream easier. And so now once you've connected to all of those different external systems or given the opportunity to connect with all of the different vectors that these forms start, and you've centralized this, you now have a pathway to push this information, this non-flattened information, digitally into the insurer systems. That can be standoff insurer portals, such as the one OKRX has, different payer systems, and these can also be CRM systems of theirs internally. The other solution consideration you need to think about is the implementation strategy. Oftentimes we want to launch full blown, but you need to launch with a plan that works for everyone today, because there's many different vectors for filling out these forms and submitting them. So you need to account for all of those different vectors and give optionality to the different stakeholders. You also need to offer e-submission, but don't force it if you want to have adoption. You need to target the early adopters and the interested parties of large organizations because they will drive the future late majority and laggards. If we look to the US as a clear example of this, EPA was introduced well over a decade ago. Many states have legislated it, but still after 14, 15 years, only 50% of PAs are still, only 50% go through EPA while the rest still go through FACTS. So that brings us to what we're doing here at OKRX today. And that is simple. We're trying to create technology that'll simplify the medication access and coverage for patients and all their healthcare stakeholders, especially those involved in prior authorization. A few milestones that our company has achieved. We are a Mars Ventures Lab company, and we were finalists in two separate, therapeutic area challenges, the Mars and Merck Lung Cancer Innovation and the Arthritis Society Ideator Awards. Our business model is because there are many different agnostic stakeholders in this in the prior authorization process, is to work with all of them. And currently we do have in-market validation with every single one of the stakeholder types affected by the prior authorization workflow, whether that's the payers, the drug access navigators themselves, specialty pharmacies who support these, patient support programs that are put on by manufacturers to facilitate this drug enrollment, and the device companies, as I mentioned, themselves. And so what I'm going to share with you today, of the 7 different solutions OKRX provides, I'm going to share with you 2 that are relevant to the prior authorization process. The first is our provider link solution, which is the first all-payer, all-medication platform that would allow secure and electronic sharing and collaboration on these forms between the different parties, whether that's patients, their prescribers, their pharmacies, other healthcare professionals like the drug access navigators, their patient support programs, and ultimately to the insurers. After we show how the provider link system can bring all of these forms to the insurer's front doorstep digitally, I will then share with you the insurer link, which is our solution that would allow insurers to consume this information digitally, no matter where they are in their technology process today. And so with that, let's start by showing you some of the external systems and how they would link with our OKRX provider solution. But before we show you the external systems, let me show you how OKRX would work as a standalone solution alone, so that all the other linkages will make sense. So what you see here, I just want to make sure you can still see my screen. I'm logged in as a healthcare provider. I'm Nick Riviera today, and I see my dashboard of all the different forms I may be working on. To search for a form, it's as simple as typing in the product medication that it might be associated with. So here I'm going to do test 2 milligrams. And once I search for a medication, it will show me any services available for that product, including any forms, which would also include the prior authorization forms for the product I selected. I would hit start prior authorization. And if I have the solution linked with other systems, I can pull records of my patients, so that I can easily start to pre-populate the forms. So here I'm going to pick Homer Simpson. I'll hit continue. And now I can search across all of the different insurers for the appropriate forms. I can also select to see all the forms that the OKRX system currently has for test 2 milligrams. Here I see that I have 2 enrollment forms that are available. And this is both in English and French. So what I will do is I will start the request for one of these prior authorization forms. And because I might work at different practice locations, I can associate that form with one of my practice locations so that other team members of mine can also work on this form. Again, you may need to take the assumption that the prescribers don't want to necessarily complete this work. They want to pass it off to members of their team. And so this would allow them to do that through the different practice locations. Once I see the form, I'm also going to mark that I have the consent of the patient to complete this form on their behalf. As their HCP, I will say it is implied. And what you see here is that form digitized and in front of you entirely from end to end, every single field, so that the user can complete it and send it around for information, signature, collection and signature. We do have this view, and we also have this view of the form, depending on the user's preference of how they want to see the information. So if I want to fill this in, I can very quickly start to automate the filling process. I can search for prescribers. So I'm going to search for Dr. Hibbert here. It will pre-fill his information. Notice that I've left specialty empty, and that was on purpose because I'm going to send this to Dr. Hibbert to ask him to fill and complete this form. System also knows that we need 2 signatures before this form can be fully complete. And so what I will do, just in the interest of time, although we can send it to patients through the system as well, their caregivers, their plan holders, and so forth, I'm going to sign on spot as the patient. That way I don't have to put you through watching me send this to two different people for signature. So I'm going to say I'm Homer Simpson, and I'm going to sign here right on spot, which is also valuable in case the patient is at the point of care setting. Now that I've done that first signature, I'm going to go ahead and send it to the prescriber. I notice up here that it has showed me that the first signature was done by the plan member and the patient. And so I will go ahead and request information and signature through the system. And it knows that I can send it either to the patient, the prescriber, maybe Homer is underage, his name is Bart, so we can send it to the caregiver as well, and any other people that might be involved in Homer's circle of care. So now let's send it to the prescriber, because as you saw, we were missing his specialty and his signature. And through the system, while we are very much trying to champion digital information exchange, we do recognize that some stakeholders today may inevitably still prefer fax. And so we do provide a fax solution option, which would provide the form to the prescriber, but right on the very front of the form, it would also pre-populate a request that tells them that this form is available digitally. They can come back by filling this unique code, this last name, and this date of birth to access the form digitally online, so that electronic chain of custody never gets abandoned. Again, a last line of defense to keep everything electronic. We're going to send this to Dr. Nick, though, electronically today. And so I'm going to put in his email. I'm going to send it to him in English, and we have a few security options as to how he can access this. For today, I'm just going to keep it simple and send it to him via a secure email link, which once he accesses his inbox securely, he'll be able to open and view the form. I will hit next here. And now what I can see is, again, that form in front of me from end to end, so that I can select the fields that are appropriate that I need completed by the different stakeholders one by one. So here I'm going to ask for the specialty, and I'm going to ask for the prescriber's signature. If, of course, I needed the doctor to attach any other documents as part of this, I can request it here as well. We can also, for every field on the form, request notes from the recipient. So I can say here, are you a dermatologist or rheumatologist? Pardon my spelling today. Now that I've sent two fields to the doctor, I will hit next. I can choose which clinic I am sending this out of in case I work across many. I can provide a note here, and I can also provide reminder notifications in case the doctor doesn't complete that. Once I've sent it, I'm going to quickly turn over to Dr. Nick's inbox and check it out. So here I am switching tabs, and I am now in Dr. Nick Riviera's inbox here in Gmail. I will check his email account once that form has been sent. And I see that I've received the request right here. So the form came in from Dr. Nick. He sent it to himself. He could, obviously, we're taking the impression that someone in his clinic sent it to him on his behalf. And you can see the request here, no PDF attachments for PDF. He will hit view request, and he will be directed to the form itself. Once he sees the form and recognizes the sender and its appropriateness, he can click start to complete the form that was requested. And question by question, whatever was asked of him, he will be able to enter. So here we see the note, are you a dermatologist or rheumatologist? So he's going to say he's a dermatologist today. He completes that question. He hits next. He sees now that the next thing that's requested is the signature. If at any point he wanted to view the full form, he could see that as well here. But he'll sign and he will hit submit. And that now will go back to the sender instantaneously. Of course, the prescriber does not need to make an account. They can quickly download a copy. But if they did make an account, they could view all of their pending requests by signing in. So we make it very easy for adoption in terms of not forcing the prescribers to have to make an account to see the forms that they need. So I will close that. I will close Dr. Nick's email. And what I will do is go back to our system here. I will hit refresh. And what you quickly see is that both signatures have been collected. The information on this form is now locked. I cannot change the information on Dr. Nick's section because it has been signed. But of course, if I clear the signature, I can add additional information if I need. So now if I'm assuming that all of this is completed, which of course we know it hasn't, but let's assume that anyway, I'm going to now be able to send this to the plan directly through the system.
Remy, can I
Yes.
ask? I've got a question.
Of course.
Somebody asked, and I think it's worth asking, just to clarify that when a physician or a PSP starts a claim, they will, the correct claim form will come up. It's like whether it's Sun Life's claim form or Manulife's or Green Shield, those unique claim forms are loaded into your system and they're updated in basically real time, right?
Correct. If the form is publicly available, our system can flag anytime it changes, and then within 24 hours, we update the form, and that way it's provided to the whole ecosystem of users automatically, the latest form version.
And as long as insurers have the software that will, to transmit the completed claim form to, then the insurers can receive the claim form electronically, correct?
Correct.
Thanks.
And so here now, before I submitted it to the insurer, it knew that there was issues with this form, because what we can do is validate every form down to the field level. And so now that as the sender, if I review these issues, I notice here that for the patient, I forgot to add their group number. So I can put a quick group number here. This allows users, or senders, I should say, from not wasting their time sending forms that are incomplete, and alternatively, insurers not wasting their time reviewing forms that are incomplete as well. Today, many insurers are receiving this via fax, so we provide the fax option. But as part of moving towards electronic prior authorization and the work we're doing with insurers, many can start to receive all of the forms that we worked hard to keep digital and non-flattened via e-forms. And we're going to talk much more about e-forms later. So I'm going to send this via e-forms so that this recipient insurer will receive it through their insurer portal directly and digitally. I will hit proceed and hit yes, and that will be now sent to them. Before sending, the system will also allow me, because it knew that I was selecting test 2 milligrams, to select any other DINs that I want to associate as part of this submission so that I can send a comprehensive review to the insurer. I will hit yes, and this will now be on its way. At any point here as the sender, I can also review and track outcomes of when this form is completed. And I will show you that here. What we are hoping to move towards eventually is that the outcomes from the insurer will be received electronically back through the system. But today, this can also be done manually. So they can put approved, the dates of approval, if there's an expiry, if it's ongoing, yes or no, the expiry date, and so forth. And through the system, the sender, once they put an expiry date, it will also remind them, once this PA is up for renewal, to start the new PA renewal process for this patient. So this was from the standalone solution. But now you're thinking, Rami, this needs to integrate with prescribers, because prescribers might be starting this from their EMR, or the prescribers are adamant that they need things stemming from their clinics. So let me stop here and move over to my prescriber EMR. So here I am in my Oscar solution for Dr. Nick. I'm going to search for my patients, and I see Homer Simpson again. From Homer Simpson's list of medications, I can see that he has 3 products on file. And we have the OKRX connector bar here, which would link and provide him the ability to initiate forms at any point for any of the medications on Homer's profile, and track the status of these forms as they are completed directly from here, never having to leave his EMR. So what he would do is he would hit add. He would see a listing of the products that were on Homer's profile. He would select the medication of interest. He'd be able to obviously enroll in the program, request services from the programs, but for our purposes here, he wants to start the form potentially. He would see no different than you saw on the standalone site, the prior authorization forms and the enrollment forms, and he would be able to hit start PA right from his EMR. Oops, I think I have too many browsers open. 1 second. This should work, but essentially it would launch you right into the form solution here again, where they'd be able to start the form. That is for the integrated approach from EMR. Now, if I close this, the next thing that we talked about was the ability to see forms or start forms if you're keeping track. We've talked about the EMR. Often there's a big role for pharmacies to play in this, because they might receive the prescription, do the adjudication, and it's right then and there that you realize a prior authorization is required for medications. So through pharmacy dispensing systems, we are also able to electronically link to the forms and PAs that might be needed. So here what I've done is I'm going to search for a patient. This is my solution linked with the Kroll pharmacy dispensing system. Once I've searched for the patient and found them in my Kroll system, it will pull their patient details into my system here, and it will also include all of their dispenses. Once I see a listing of the dispenses, I will see if there's any appropriate forms for that particular medication. I can select the medication, and what I'll see here is if I have started any previous forms for this particular DIN, if I've started any previous forms for this particular product, maybe it wasn't the Lenvima 24 milligram, but the Lenvima 20 milligram instead. And I, of course, can start a brand new form for this product anytime I need. And again, this is linking directly from my pharmacy dispensing software at this point for those stakeholders that are pharmacists who are involved in this process. And so here again, once I've selected the form, I can go directly into it, and any information that you had from the pharmacy dispensing system, no different than the prescriber's EMR, would autofill that form for you here. And so now continuing here, we've talked about the pharmacy dispensing system. What happens when forms start from a CRM, such as from the patient support side, or from other websites like Drug Access Canada? Here as an example is both of those solutions. In the first example here, I am working from a patient support program CRM for Maggie Simpson. I'm in her insurers tab, doing a prior authorization on her test product. At any point, I can hit view form, and it will pull the information that is provided on that CRM, whether it's the patient listing, prescriber listing, medication details, insurer details, program details, and it will again pre-populate that form. So by this point, you can start to see that even if you created the form as a standalone and you link it to other solutions, all of those pathways lead back to the same experience where you can then send this around for information signature and collection while maintaining everything digitally and in a PDF compliant or accessibility compliant fashion. So that is starting a form from the CRM. And finally, which may be very valuable to many insurers, you might have forms that are listed on your website where you're currently only making them available for download. What you can also do is add the OKRX button here that would allow any user to start the form digitally from the OKRX system. And again, all of this is made possible because we've digitized the form in one central agnostic place. So here is again is that form that could be completed. So I will close these windows here now, and I will talk about one final solution. But before I do, just to recap, when we connect to any of the connected systems, whether that's EMRs, pharmacy dispensing systems, or CRMs, our published APIs would allow you to pull all the different information that may be available from those source systems, whether it's the patient, prescriber, plan holder, pharmacy, medication, and PSP details. Of course, in the absence of these connected systems, the users would still be able to do all of this information, although it would be entered manually. So there's still two ways to work. But let's say that you are an insurer or you are one of these stakeholders and you have all of 2023 booked up already. You do not have time to integrate into other systems. What we can do, and one of the best and easiest ways to work together, is to create your current PDF library into smart PDFs. Now I will show you what happens when you create one of your current PDFs that you make available to the market today into a smart PDF. What you do is we simply add buttons to your current PDF document, and I'll show you a video of this quickly here. If it would only load. And so the first thing we're going to do is collect signature from the PDF that was created. What you see here is that form opened Adobe PDF and been completed so far by a user. So take the scenario of a clinic or a pharmacy who's been provided the Sun Life, Manulife, Canada Life form, has it already digitized as a smart PDF, and now they filled that out on their desktop or through their browser. The first thing you should note is that not everyone has a signature solution. Not everyone has a DocuSign account. Not everyone has an Adobe subscription. So what I've done here is I've clicked the signature box, and what we can do through OKRX is digitize the entire form. And once they click the signature section, it will pull all of the information that was on that PDF, bring it to the digital version, and then allow the user to sign digitally. This is in the absence of any Adobe subscription, any DocuSign. They were literally brought to a browser from their desktop solution and now have the ability to sign the form electronically so that nothing is lost in terms of the data and nothing is flattened. The second thing we can do once that has been completed is through the smart PDF, submit all of the information on that PDF directly to the insurer. We do that by adding a button that says here, send to insurer. What it'll now do is pull all of the information that was put into the fields on this desktop PDF, pull it into a digital version, and now allow this to be submitted into the insurer, as you'll see here. So you notice the first name and last name, all of the information on the street address. We hit proceed. And no different than what you saw with the standalone solution, it's going to ask for which product this PA form is associated with, because it knows which forms might be linked to certain products. We will hit submit. It will do again the validation check, even from the desktop, and tell you if you missed any forms when you transplanted that from the desktop. So again, here they're filling out the group number. And now they can hit done and again send it directly through the system to the insurer digitally. So again, if at the very least, what OKRX can do for insurers today is digitize their form library, add a button to their existing PDFs, and as users access those forms from their websites, they would still be able to send it to insurers digitally in the complete absence of working integrated with any other EMR or pharmacy dispensing systems. So now we've done all of that work to connect provider link with all of the upstream systems. We've housed all that data electronically, and now we can send it to the different insurer systems. Today, insurers are using many different systems, and many are on different points in their technology. Some are looking to replace their technologies internally, some are not. What we found is that many insurers will tell us that OKRX has done a great job of bringing all of this data digitally to their doorstep, and now the challenge is them absorbing it into their current systems. So what we have done at OKRX is built 3 different ways that can be done. The first one is through a standalone insurer system that we've created called InsurerLink, and this works as a holding tank, so to speak, so that any of the information collected digitally that the insurer is not able to absorb digitally today can be left in there so that workflows can happen out of that system. If, of course, you're an insurer who has sophisticated systems and are ready to make those integration, all of the information and processes you see, or I'm about to show you in InsurerLink, can happen directly into your payer systems, whether that's a unique system or typical systems like Salesforce. And so again, the InsurerLink is going to connect directly to payer systems and work to automate the prior authorization process. It has out-of-the-box workflow features for intake, initial review, clinical review, outcomes management, communication back to different stakeholders, KPI tracking, and analytics. And so what that looks like is the initial intake. OKRX will check the form for any errors and omissions before it is submitted. Once it is submitted, OKRX identifies the form and connects it to the associated drugs, criteria, and workflow for that particular form that was submitted digitally. OKRX then extracts all the information from that form and adds it to the database so it's fully searchable and actionable. OKRX can then search for the appropriate plan member and prescriber from the payer's databases if they are linked, so that they can identify the appropriate plan member or prescriber. If the plan member and the prescriber can be matched, the initial review is completed and you can move to the clinical review sections of this process. Once you're in the clinical review, and again, this is all highly configurable from insurer to insurer, OKRX provides the criteria for clinical evaluation, both the initial and review. OKRX will place the form in the appropriate initial clinical evaluation workflow, and this again is configurable based on the organization, the group number, the DIN, or the form type. All of this is automation possible. OKRX will also allow you through its communication engine to collect further information from stakeholders that may have been missed on the form. Once that is complete, the clinical reviewer can also do their assessment on the form so that the review is done. If now we're on to the outcome stage, the outcomes can be initiated in either the payer system or OKRX and communicated back via API to the senders. This information allows insurers to inform stakeholders about the process and the outcome at any given time. This will also allow for expiry date follow-ups, clinical outcomes, adherence reviews, and so forth. And this would all lead to data generation that would allow for better KPIs and case reviews. So let me now show you the insurer system in action. And again, I want to emphasize that the insurer system, while it is a standalone solution, it is meant to be a bridge so that all of the information that was received here digitally can make its way eventually to the insurer systems of your own. In the time being, until that is realized, this solution can be the middle ground. So what you see here is that form that we submitted for Homer just a few minutes ago, about 12 minutes ago, and is now landed in my intake section of the insurer portal. When I click on that form, I will see all of the steps that I may have configured as part of my review process for this form. Again, every insurer can log in separately. They will have their own unique review process, their own unique criteria, and all of their unique steps configured. If they need this solution just as strictly as an intake process, they can do so and then link all of the other downstream processes to their internal systems if their internal systems have the rest of these processes and steps taken care of. So first thing I'm going to do here is I'm going to look at the intake or the form that was received. I want to make sure that it was sent appropriately. And I see all of the information that was provided here on the form and all of the digital fields. I see the signatures. I see dermatologist here. I see my signature. And of course, I can download this form if I need to for any records. I can also now choose to either discard the intake that came in or accept it. Once I hit accept, I'm asked where I want to take this form as the next steps. Do I want to send it to the initial review team or do I want to send it to an individual member? Again, a reminder that every single one of these process flows and steps this solution here can take it from end to end, or at any point, it can hand off the process to your own insurer internal systems. So I'm going to say that I'm going to do the internal review here as a team. I'm going to send it to the initial review team here. And then the next set of cascaded steps would appear for me. So the initial review. First thing I'll do here as the patient is I'll do the patient review. And it would pull any information that corresponded to the patient or the plan holder from the form and populate it here so that I could copy that information into my system. If I'm working with an integrated system with the insurer and linked to them, what I could also do is if I hit get info review, it would pull any relevant Homer Simpson records from the insurer side to see if there's a match on the patient. If there was, it would appear here and you could link the patient. Of course, this is a demo environment, so we haven't linked to the insurer system here to show you that. So I'm just going to quickly finish this here. I'll hit update. And now I'll confirm the patient. The next step is the prescriber review. And again, similar to the patient review, I can choose to copy the information that was provided from the form, see if I have a relevant doctor in my system that matches this doctor. And I can also complement the record if I need to. And lastly, I'll review the drug and product. And each one of these steps, as I mentioned, can be turned on or off depending on you as the individual insurer's way of working and your internal process flows. So remember that the drug was sent for test 2 milligrams. They asked for the other drugs. This now knows that as the system. So it's highlighted all of those additional DINs as well for coverage. So here I will confirm. And everything, as you can see, is timestamped and shows you how long each step of the process took for KPIs. So now that I'm on to clinical review, many times we hear that the insurer's criteria is their secret sauce. This would allow a unified agnostic central solution while every insurer still maintains their secret sauce for criteria coverage, both on initial and renewal. What I will show you here is how we could review the criteria through the system. So for the form that was submitted, it was for prostate cancer, and there was 2 types of clinical criteria for prostate cancer. I can start the evaluation for this criteria or for this one. And when I look at the criteria here, it will show me the sub-criteria points that go into assessing this PA form. So here, for example, there are sub-criteria of whether they received androgen deprivation therapy, if it was in 6 months, so on and so forth. And I can begin to answer at the sub-criteria level one by one, whether it meets criteria, doesn't, and so forth. So I'll say here, meets criteria with an explanation, meets criteria. And this again is for the initial. And I have the ability also at any point to add notes for each one of the sub-criteria section. Once this is all done and I've reviewed the criteria, that sub-criteria, I can render it a decision. I can also write notes associated with this decision. And again, this is all in the absence of if an insurer does not have a system that can currently do this for them today, and if they don't have a good mechanism today to receive all the information we've landed digitally at their doorstep. Now, if I go back to my clinical review and my criteria, I will see that of the form, and there might be many different criteria evaluations on the form. I did the first one, everything looks completed and is okay. I didn't do the second one. And so now I can mark that the criteria is complete. And this is again where, depending on the insurer's processes, you might have a level 2 escalation, you might have a clinical escalation where you send this externally for review, or you might just want to proceed to outcomes. And again here, if you proceed to outcomes, either in this system or your own internal systems, all the APIs can feed back to the sender so that once you enter an answer here, such as approved, that can be fed back to the stakeholders that sent the form.
Remy, how many insurers have a system? You said they can use this if they don't have anything else to receive that electronic claim submission from a PSP or doctor. So how many insurers actually have a system that can catch those claims? And how many would actually need a system like this that just don't have anything right now?
So the answer is every insurer has a system. It just really depends on the level of sophistication today on their systems. Some are making those active investments. Others are kind of looking at the landscape to see what they can integrate with to better prop up their systems. The answer is regardless of where their system may lie today, they might say, I'm going to completely adopt an external system that can just feed through API A and B to my system, or they might say, my system covers all of these checkpoints. I might just need the OKRX Insure system for the initial review piece, and then all of this be done in their internal system.
And it
So
can just flow from here right into their system.
Exactly.
Yeah,
so this holding tank.
Okay, thanks.
Yep. So this holding tank, so to speak, was created so that regardless of where you are in your technology journey, it can either accomplish the entire workflow process for you or plug into your system exactly where it needs to fill those gaps. And so now that I've approved it and given it an outcome, of course, there's also the opportunity to communicate through the system here to the different stakeholders in case anything was missing. So now if you're thinking to yourself, well, Rami, you sent this from your system and now you received it from your system, that might be cheating a little bit. What if someone sends it via email, or what if someone sends it via fax? Well, it's as simple as this. If you hit that a new request was received, you have the ability to drag and drop those files into our holding tank portal, so to speak, called InsurerLink. And what I'm going to do here is I'm going to open up two different types of PA forms from my desktop. The first one you'll see here is a PA form I may have received via email. And just give that a moment to open up. This looks like the typical prior authorization form that many people might receive through their eFax potentially, or through email if it stayed digital. And what you'll notice is all the fields here still stay digital, so I can type into it. It's not flattened. So I'm going to take this PDF and I'm going to now upload it into my solution. Oh, sorry, I don't know what I did there. And I will allow the system to now analyze. Because we digitized this forms, immediately the system knew which form it was, and it asks me how it was received. So I will say that it was received via email as a digital form, when it was received, the time. I can also put in who sent it to me. So I'm going to say Dr. Nick, okrxmd@gmail.com sent it to me. And I can also search for which product this was associated for. It knows which products are potentially on this form, and now it will ask me to clarify which one it was for. So I'm going to say this was for test 2 milligrams. Once I hit add, this form that was received to me via email off of a PDF, oops, something went wrong. I think I entered the wrong receiver time, would come back into my solution here. And what I can then do is no different from what we saw with the form that was received digitally. I would be able to take it through all the end-to-end steps of the process that I showed you. Now, what happens if that form is received via fax or eFax like many are today? I would again hit new request. I would drag and drop the file, only this time I'm going to show you one that is flattened. This clearly came to an insurer. You can see here at the top, it came through a fax the way it looks. And of course, I can't type into this one anymore because everything here is flattened. So let me drag and drop this form into my system. And now the system will do the same thing where it will analyze the form, but the only difference is it will not know automatically which form this was. So I will have to now search by looking at the form, which form this was. The second I give it a name from our library of forms, it will again ask me how I received this form. So I will say this was faxed, or sorry, emailed and it was flat. And I received it yesterday at this time. I will also say who sent it. Exact same steps you saw right before. If any attachments had been associated with that submission, I could also drag and drop them here. And I'm going to search for the product again here. I'll hit test 2 milligrams. I will hit add. And again, same issue with the receiving. But now what would happen is this form would come into the system. It would recognize because I selected which form it was, and it would now give me all of the fields again pre-populated. So that end-to-end is how our solution could work, both from connecting to all of the different systems that can send the form, and then the method that which we can communicate it to insurers, whether they want to receive it digitally into our system or theirs, across all the different types of form submission types they receive. And with that, Denise, I will hand it back to you.
Thanks so much, Rami. We really appreciate you you being here with us and going through that information. We do have time before we move to our panel discussion for a couple of questions. And I have been monitoring the chat box and sort of going back and forth a little bit with folks. So I maybe, because I think for some people this is new, and so it's amazing, but it's a lot to take in. I mean, I've seen it so many times now, and even then I learn something new every single time. So I think, some of the sort of discussion points or questions that have been coming up in the chat box, I'd just like to, go sort of spot check into. And one is, and I know we've talked about this in the past, but it's the coordination of benefits. Is like, if somebody has coverage under their primary insurance carrier where they're an employee, but maybe their spouse has coverage elsewhere. So can your system handle that?
The ability to work across multiple insurers?
Yeah.
Yes. So again, I've shown a few different integrated solutions. If say this was stemming from the pharmacy platform, right? It would know the different coverages potentially that the patient was on. It would know the different forms that they must go through. Okay. Yes.
Yeah. And so in terms of insurers, what kind of reception have you had from insurers on, this kind of approach to creating an electronic prior authorization solution?
I would say that the approach has been overall positive. Everyone recognizes the need for something like this to move forward. And there's been several reasons for the positivity. One is, the largest goal, which would be potential EPA one day. But even as we build towards that, the ability to have all of their forms digitized, the ability to then put those digital forms, because it's digitized, attach it to their different websites, payer portals, different other solutions. The ability for them to now start to think about things in a digital fashion has been very positive and not something they'd considered beforehand too much. The positivity sometimes gets eroded by where their current systems lie today and what they plan to do long term. Everyone wants EPA. It's just a matter of how their systems will work to coordinate that on day one, because they're all coming at it from different steps in their technology stack. And
what you've talked about in demonstrating your system is, there's so many different stakeholders that will touch, we know that are touching the paper process now, but that need to touch the electronic process. So when, just to go over again, when say someone is starting a claim, it could be a physician, right? It's not going to be the patient, right? Physician. Yep. What other stakeholders, just to go over again?
Drug access navigators could be starting it. It could be someone starting a prior authorization at the pharmacy. Again, we for sure, prior authorization is big in specialty pharmacy, but you have to remember it's getting more common for even like what we'll call primary care medications potentially. Right. So the pharmacist also plays a big role in prior authorization management. So making it also work for their solutions is important. Drug access navigators, right? Some are standalone, some are using pharmacy systems to help manage with their workflow. Some have access to the EMRs. So however you create the forms and the workflow, you have to account that everyone might be starting the form from different places and might be using different solutions to do so.
And so your system can handle that.
our system can handle that, and any system needs to as well. I mean, I
Yeah.
think we showed during the presentation that as much as we're trying to forge things ahead electronically, we went all the way back to the paper-based PDF, right? And if your stakeholders are adamant to just, let's say, use the PDF in Adobe, you have to also meet them there and work with them there as well.
Yeah, on their terms. And I think that, when we talk about, and we've explained this actually in the new website, when we talk about electronic prior authorization, what we're really talking about today is first generation, right? So maybe you can just explain the difference between what we're talking about now and what a true EPA system is. So right now we're sort of using the term EPA loosely, but there's a difference, isn't there?
Yep, and you have to obviously like walk before you can run. And why we are doing things right now. So true EPA would have no forms. It would be almost formless forms, so to speak. It would be a series of questions, predominantly yes, no's, that would ask, did the patient try this before? Are they above this age? What's their gender? So on and so forth. And then from there, responses can be rendered in real time. Because everything is so predominantly paper-based today, we can't move away from the paper anytime soon to that true formless forms process. So the best approach at getting to true EPA is to work through the paper era today, where all of the information that's on the paper can at least be converted to digital, receive digital, and then from there, you can start to make forward progress towards eliminating the paper altogether.
Yeah, okay, fair enough, great. So in terms of, what your, in terms of the stakeholders that are adopting this, how do they actually get onto it? Like, do they have to sign up with you, or do you approach, physicians and DANs and PSPs? Like, how does somebody actually get access?
Great question. So if you are a patient in the patient circle of care, let's call it the healthcare provider. So if you're a prescriber, a drug access navigator, or a pharmacist, or a PSP provider, you can use the solution today, or you can sign up and create a free account to start using the forms on OKRX. Where we work is with the pharmaceutical manufacturers, the PSP vendors, and the insurance companies directly to ensure that the library is kept up to date and is working for those intended users, the patient and their HCP circle of care.
Great. Okay, good. Well, Remy, I think I'll stop it there. I know you're going to be sticking around for the rest of the session, I think. So, and John obviously is going to be part of the panel, your associate. So I want to thank you very much for a very thorough review. And as I said, every time I see, your demo and your presentation, A, I learn more, and B, I see you've added more tricks into your system. And it's so nice to see that the insurers, as you always tell me, the catcher's mitt is there too for insurers. So whether it's their total solution for catching and managing prior auth, prior auth for drug claims for usually for specialty drugs, or whether it's sort of it can then feed into their existing systems. It's nice to have that full spectrum solution available in the marketplace. And you know what? I think we can really beat the Yanks. Like, let's just show them how it's done, right? If they can't get their act together, let us Canadians do it.
Sounds good.
Great. Well, thanks so much again. I know Ramy's going to go dark, and I'm going to invite each of our panelists to join me one at a time. The prior authorization process, Ramy mentioned this. It was developed, he said 10 or so years ago, but honey, I go back way further than you, and it was around a long time before 10 years ago. It was on like one or two little drugs, and nothing happened for a long time until we started getting into sort of biologics and other specialty medications. And really, it's just exploded over the last 10 years. So we right now, because of the prior authorization processes that are in place, we have, as you will have seen, a very complex network of stakeholders between, the prescriber and the patient receiving the medication prescribed. So there's a whole bunch of stakeholders in between. You've also heard about two of the responses to this complex environment. The one that I've been working on with my team, provides a central resource for all things prior authorization, as well as an advocacy for change. And the other one provides real solutions to moving that paper trail process that currently exists onto an online platform. So now what we'd like to do, and this is the first time in any of our webinars we've done this, so I think this is really exciting, although it's a little bit chaotic to organize it all. You're going to hear from our panelists, and each of them, I'm going to introduce them individually, are going to speak to you for about 5 minutes about their role and their observations on prior authorization. And then what we're going to do is I've prepared some panel questions, and we're going to tackle as many of those as we can until we end at 3:30. And then I've got the chat box open as well. I'm going to share my screen. I'm going to kind of do some jumping around here, share my screen so that you know who our panelists are as we work our way through. And I will invite each of our panelists, as I said, to show themselves. So I'm going to start with, actually, Ned, you're not up yet. You can go dark again. Sorry. I'm just going to share, let's see, I'll just share my screen. So while we're doing this, and John, I need you to show your face. Where are you, buddy? There you are. Okay, great. So John is the president and CEO of OKRX. So I thought it would be good to start off with John. John has an incredibly varied background, but it's all in the healthcare sector, practicing pharmacy in a retail and hospital setting, and also in direct patient care and management. He's had experience in the pharmaceutical industry and in more positions that I'm prepared to talk about right now, but they're in his bio in your agenda. He's also seems to be a bit of a serial entrepreneur. So he co-founded Patient Direct, that was a patient support and specialty pharmacy provider, AIM, an infusion services provider, and GMD Distribution, which was a pharmaceutical distribution, patient support and specialty pharmacy services firm. That was acquired by McKesson Canada. Well, John has firmly landed in the quagmire of prior authorization, and I know he's been around that space for a long time now, so it sounds like you found your true home. He's a pretty clever guy because not only is he a pharmacist, I'm just going to see if I can say this all the way through. He's also has a PhD in a pharmacoepidemiology. Hey, not bad for a no science degree at the University of Toronto. So John's going to give us, some further thoughts on prior authorization and kind of where we are and where we need to go to. So John, I'm gonna go dark.
Well, thanks so much, Denise, and thanks to the Simply Prior Auth team and the sponsors for the invitation to the panel today. It's great that Simply Prior Auth is raising awareness on this issue. And like Denise said, I'm John. I'm the founder of OKRX, and obviously we provide technology solutions to support healthcare providers and patients who require complex medication therapies. And of course, the prior auth process is central to many specialty medications, and so we have a keen interest in modernizing this process. And I think we heard Rami say a little while ago that the prior auth process might be around 10 years old, and then Denise referred that it might be a little bit older than that. But I actually do remember my first prior auth back in the late 90s. And it was for a friend who I went to school with, and it was for the drug beta-seron. And basically, the first time I ever saw or heard about a prior authorization form was when my friend brought it into me in my pharmacy, and we filled it out together and sent it to his doctor to complete and sign. And eventually the doctor faxed it back, and then we faxed it to the payer. And to take away to me is that, that was probably, I'm not sure it was 1999 or maybe 2000, but how little that process has changed over the last 25 years. We went from payers having literally a handful of prior authorizations to now payers having well over 200 prior authorization forms. And alongside this, there's been huge increases in the number of medications requiring prior auth, as well as the number of doctors and nurse practitioners prescribing these drugs, the number of PSP providers and programs supporting the patients and HCPs in these therapeutic areas, the number of specialty pharmacies involved in dispensing, and so on. Yet with all this growth and stimulus, the prior auth process really hasn't changed that much. In fact, probably the biggest change over the last few years has been the adoption of the electronic signature technology, things like DocuSign and so forth. And while the signature is definitely an important part of the process, at its heart, the prior auth process is really about information sharing. And the reality is that over the last 25 years, the way prescribers and doctors share information with payers about the need for potentially life-changing therapy hasn't changed much at all. It's still a piece of paper that gets faxed or scanned to or scanned and emailed to a payer who then does their best to decipher it. It's really not that different than my first beta-seron patient back in the late 90s. And so my takeaway is that we've been talking about changing this process for quite a long time. And at OKRX, we've started to take the first initial steps into creating a process that would be compatible with what everyone is familiar with today.
Thank you very much, John. You didn't take as long as I thought, so well done. I think that's a great synopsis of kind of where things have come and how far along we've come, which is really not very far along at all. So until the last couple of years, I would say, in the development that you and a few others have done. So next, if you can go dark, John, and I'll invite Dr. Alan Lowe to come back to us. Alan, you there? Oh, there he is. Great. Alan is joining us from BC. He wears many hats. I'm going to name a few of them. Dr. Lowe is a primary care pharmacist at BioPro Biologics Pharmacy, care director at Medifuse Infused Health, and clinical pharmacist at Fraser Health Authority, and has a devoted interest in patient-centered care and interprofessional collaboration. He's also practiced in many areas of hospital pharmacy, the pharmaceutical industry, academia research, community pharmacy, and patient advocacy. As an advocate for patients and patient-centered care, Alan also trains and educates healthcare students and patients on many therapeutic topics, and I hope he teaches them about prior auth, because as far as I know, that not much is taught in the pre-grad programs, health sciences programs, about the quagmire that we're in with not just public drug coverage and but also with specialty drugs. So as an active patient advocate, he's also the executive director of the Medicines Access Coalition in BC. And I'm very thankful that you've made time in your schedule on BC time to be with us, and look forward to hearing your observations working in the trenches of prior authorization.
Thank you, Denise. Thanks for that introduction. And with the many perspectives that I have on prior authorization, it's great to see that there is an initiative to try to simplify it. It is a very complex process and procedure, and I will try to limit myself to the 5 minutes, but there's so many things that I've seen with regards to prior authorization that there's certainly a lot to talk about, and there's a lot to be done. And I think we'll hear over and over, it is these authorizations and getting coverage that is the major source of delay in patients getting their medications. And sometimes that delay can be months, and even ends up where patients aren't able to get on the drug at all because things just fall through the cracks. So the more that we can streamline this process, make it simple, and also we all know that paperwork is also a huge burden for healthcare practitioners and anybody who's involved in healthcare. It's just so difficult to deal with the mounds of documentation. And of course, the more that we can automate it and make it electronic, as well as keeping it secure and private, is of course another very important issue when we talk about health data. So I'm going to talk about a few different perspectives or views that I've seen that maybe can stimulate some conversation, and also provide a perspective and insight into the group and the audience that's here. So I'll just begin with the fact that, before we had patient navigators and patient support programs, and as John was speaking way back when, and so I've been practicing for a long time in pharmacy, and also in the same areas where the first prior auth I was exposed to, working at the MS clinic at UBC Hospital. So I was a pharmacist specialized in neurology and working with the MS patients. And that's probably the first time I saw it. And, before these support programs and drug navigators and essentially coverage navigators showed up, pharmacists and pharmacies essentially did it all. And it was any paperwork that was required. It was basically anything that you had to do to ensure the patient got the drug, whether that be just the procurement aspect of it. And some of these more specialized drugs were harder to get. Sometimes they were locked down and wasn't available to all community pharmacies, and you had to orchestrate getting that, as well as dealing with any of the paperwork, approvals, prior authorizations, and coverages through the public plan in order to ensure that the patient was covered or was least out of pocket with regards to the financial aspect of it. And so this is kind of where we're coming from, where pharmacy has been very involved. And now with the drug navigators and drug access navigators on board and patient support programs, in some ways it's alleviated some of that workload, but in some ways it's also made it more complex. So myself and my team, we probably deal with over 50, that's 50, different patient support program and navigators. And that's a lot of communication. Of course, each of them do it differently. And then we're also talking about all the different insurers that may have different requirements, as well as dealing with the public plan. And of course, for these expensive medications, when we talk about specialty pharmaceuticals, they're all going to go through a public plan if it's listed on the formulary. And in BC, we've just recently introduced an electronic prior authorization or electronic special authority process that was piloted last year and is now beginning to be rolled out more broadly. And hopefully that will make things a lot more simpler, as well as expedite the process. And we have seen that happening already. So this is through BC PharmaCare, and we have seen a dramatic improvement in how long it takes for a special authority to be approved. And now we have visibility of it because it is electronic, because we think back to how it was previously done and where most of the country is still dealing with fax or a paper format of this. As Rami was talking about, a paper format is flattened. I mean, it's not searchable. You can't find it in a pile easily. And this is essentially what we were dealing with BC, with special authorities that were sent in. If you were to call up PharmaCare, and we do this often to find out, where does this stand and how long we can expect still for the approval to go through. It's not easy for the person at the PharmaCare end to try to find that application if it was sent in by fax, because there are a pile of faxes. And for a period of time last year, due to some of the prior auths required for some of the insurers to get essentially what's called a negative special authority, refer to it, basically needing a rejection on the coverage of drug by PharmaCare so that the private insurer can then take on the coverage. They had 50,000 applications kind of all come in at once. And so you can see the types of burden that faxes might be, and you can't easily select through to prioritize and find out which drug, which patient, and that kind of thing. So going to the electronic process has certainly been a really big improvement in working with BC PharmaCare and Special Authority. I can see that if we can move towards that in a prior authorization with the private health plans, that's going to make things a lot easier. But of course, the difficulty is getting all the insurers on board using the same platform, because what's really going to be tough is if we have to log in to multiple portals like we do now with some of the different insurance plans and different navigators and support programs where we might have to access information. It's better to have a one platform approach. And I think that's why it's working for the public plans. Of course, everybody is involved with the public plan, and it's one-stop shop, and you log in and look up, I guess, in one place, which makes it a lot easier. So we've tried to do a workaround and alleviate some of the concerns from a patient perspective. We hear all the time that patients are always asking, when's the drug coming and where is it stuck at? Sometimes it's up to the patient and they're stuck. They're needing to fill out forms and they don't quite understand it. And it's really difficult for a healthcare professional to try to use that time, not the best use of their time to navigate a patient. So it's great to have the drug access navigators, the patient support programs to assist patients, but still they're needing to log into different areas, fill out different forms. All of that needs to be improved somehow. And, this is a completely different, separate aspect. I wasn't on this panel because of my use or involvement with OKRX, but after doing a bunch of research to figure out what can help us in dealing with prior authorization, we landed on actually using the OKRX platform. So this is something that wasn't related, and Denise—
We're not paying you for this. I didn't put you up to this, did I?
Yes. And we got connected through a completely different way and actually introduced, I think, through one of our other panelists here, Rachel, who's going to speak later, completely independently. But it turns out that this is a platform that we're using in the pharmacy and has been tremendous in helping to get those forms completed and getting it to the physicians and the prescribers so that we can get that response quickly, rather than, again, going back to fax, because that's what normally happens. And you can imagine in a busy clinic, we send over to many physicians' offices where there's 10 physicians working in a clinic, and they kind of share a fax machine. Well, it's a lot better when we can use this platform and it goes directly to their email that they look at daily. So,
Yeah.
there's some real improvements when we can go electronic. So I'll stop there. I know I'm
Great.
probably over on time, Denise.
That's okay.
Just so much
Thanks.
to talk about.
Thanks very much. No, Alan, thank you very much. I really appreciate you being here today, and appreciate your observations from kind of that, said down in the trenches, really working with patients, trying to get their forms coordinated between their physician and their and payers. So you can go dark again, and I'll ask Rachel Mannion to join us. There's Rachel. Hi there. Rachel, I have to say, has a special place in my heart because she's on our advisory board, and she has dedicated hours and hours to helping us and guiding us, and actually referred me to Dr. Lowe as well, and providing that patient perspective on developing and advocating for a better prior auth process. Rachel is a JD, I think it's a jurist. What's the JD?
Juris Doctor. Yeah.
Doctor, that's right. Or in other words, a lawyer, and the executive director of the Canadian Skin Patient Alliance. And in her current role, she advocates for better patient care. She is also the chair of the Patient Advisory Council of the Skin Investigation Network of Canada, Skin Canada, and was also in the past senior associate and director of research with 360 Public Affairs and a legal counsel with the Government of Canada with the Department of Justice. So Rachel, I know you have a lot to say on PA, but you got 5 minutes.
I always do, Denise. And I'm not going to belabor it because I know we did a whole podcast about it. So
that's right. You were a recent podcast. Yes, that's right.
That's right. Is really fascinated by Denise and me chatting with each other about it. Can check that out. But one of the things that there's a couple of points that I just wanted to raise at this introductory moment. So as Denise mentioned, I'm the executive director of the Canadian Skin Patient Alliance. That is a national not-profit organization here in Canada, and we're the only home for anybody who is impacted by a skin, hair, or nail condition. So there are more than 3,000 of these conditions. That includes different kinds of skin cancers, and it also includes more than 1,000 rare diseases. So when I think about the future for skin patients, I see prior authorization playing a significant role for many people. Either we'll have a skin patient community that is experiencing some incremental innovation, and I think really quickly of the psoriasis community. And we know that when those newer drugs come online, they're all really subject to prior authorization processes. And sometimes, we'll also see a lot of off-label use. We're a community that is experiencing more and more tailored treatment options. So that's really exciting for people who have been using or have been treated with something that wasn't designed necessarily for their condition. It wasn't even trialed in the same way when it sought Health Canada authorization for that. But a lot of things are used off-label. That is a really, really large part of dermatology practice. So when somebody needs access to something in an off-label for an off-label indication, prior authorization and those processes can also be involved depending on what's going on for the person and the drug company and their perspective on that. And an example that I would offer you would be pemphigus or hidradenitis suppurativa. Both of those are really, really impactful skin conditions. And there are not a lot of things indicated specifically for them. But the treatment arsenal, to use a really violent analogy, the treatment arsenal is very, very large for hidradenitis suppurativa because a lot of things are used off-label. And then for pemphigus, there is a biologic that's used often to try and manage what's going on for people who are living with pemphigus. The other piece that I wanted to sort of raise at the outset of our discussion is, we know that there are many delays for patients to access safe, effective, and affordable medications, and access to private insurance plays a really big role in helping bridge that gap for patients. It can help make things faster, and it certainly historically has done that. And it can also make things a lot more affordable, and that for some people equates to possible as opposed to impossible to use that treatment option. Now, when people are sick, and I'm sure everybody on the line has been sick at some point in their lives, or they have somebody in their life who has been really sick. One
one of the first things that happens is you start to lose control over things in your life. You start to lose control over perhaps how your body is functioning. The way that you used to balance your mental health can sometimes be shaken or completely thrown. And one of the things that a successful prior authorization process can do is it can help patients come up with a plan and figure out if that plan is going to work quickly. It doesn't leave them in limbo. If patients can get to a yes or a no faster from their insurance provider, they can start to figure out what the next step is. Is it possible that some of the information just wasn't included? I know Rami showed us a lot of those specific criteria with the example, was this used within the last 6 months? How old is the person, et cetera? Is it possible that the patient has actually met those criteria and that information was just not conveyed? Was there a misunderstanding? Or is some of the information missing? Is there something else that they have to try to get to a place where they can have access to something that might be more successful for them? So as much as I would like to say that more of the no's should become yeses, and that's a totally different conversation, really what we want to do with the prior authorization website that Denise showed you at the outset, and with a lot of the work that OKRX has put into the system that Rami showed everyone, is we want people to be able to get to that yes or no faster, because then they can start to change their plan, tweak their plan, revisit their plan, but they can still feel like they have a plan. They're not stuck. I think it might have been a couple of years ago. COVID time is like its own timeline in our brains, I think. I remember having a virtual patient conversation with a bunch of patients virtually. And one of the people was telling us about experiencing a flare of their psoriasis. And they had been prescribed, so they were on a treatment that had required them to go through a prior authorization process, and they were using this treatment. And then in order to manage the flare, their physician wanted them to hop over onto a different one just to manage the flare. And then they were going to figure out if they're going to stay there or go back, whatever it was that was going to work out best for that individual. And that patient had been waiting for 6 weeks just to hear the outcome of that prior authorization process. And Alan, you highlighted that sometimes things can get stuck at different points, and sometimes things get stuck with patients. It's not always out of their hands. But in this case, all of the information had been submitted. This person was living in a very significant flare in the middle of a pandemic for 6 weeks. So we just want to make sure that these processes are moving faster so that people can come up with what they need to do next. Thanks, Denise.
Thanks very much, Rachel. Really appreciate your perspective and, of course, all your support and assistance on this initiative. So Ned, where are you? I've been telling you to go dark, and now we need you back. There you go. How are you today?
Good, thanks. How are you?
Good. I'll just give a quick introduction for you, Ned. Ned Poistkich is the Vice President of Pharmacy Benefits Management at Green Shield. He's been with Green Shield for 8 years and has had progressively senior roles. He's also been the Director of Health Policy at the Ontario Pharmacists Association and a policy analyst for the Health Professions Regulatory Advisory Council with the Ontario Ministry of Health and Long-Term Care. You might think that because we're sort of in an environment of PharmDs, when we talk about this subject, that he's a PharmD, but he's actually has his doctorate in public policy at the University of Toronto. And I know you've done a lot of research on pharmacy and pharmacy practices and processes. So great to have you with us today, both to sort of speak about the insurance industry in general, and of course, using your knowledge of pharmacy as Pharmacy Benefits Management Vice President at Green Shield.
Great, Denise. Thank you so much, and appreciate being here today. It's an interesting topic, obviously, prior authorization, one that doesn't often get standalone attention, right? At conferences, at discussions, mainly I think because it's a mechanism towards an end goal of coverage, of course, as we've heard today. And so, from the perspective of everything that I've heard so far, I'm fully aligned, and I agree. I think that the process, I think John said it best, like the process is just an information exchange, right? if you think about it just from its most basic principles, the goal that we have as insurers is to keep plans, to provide effective coverage for plan members, but be able to keep plans sustainable, right? And one of those sustainability mechanisms is to ensure that the patients are taking the drug, are being prescribed the drug for appropriate condition, right? And prior authorization serves as a mechanism to really do that check, right? In some cases, prior authorization is not necessary, right? So we do have mechanisms and structures to look at our systems and past claims history, for example, to say that somebody has tried drug X, so they should be allowed drug Y. There's really no reason to ask you to put that on paper yet again. So we invoke those mechanisms in our systems. But when we need additional information that isn't readily available in our system, such as a patient's weight or their status on a particular scale or whatever the case may be, then of course we have to go the route of seeking that information, right, from the patient. Of course, now we have this whole infrastructure that has been developed around patient support programs that is kind of the intermediary to help ensure that help the doctor navigate this process, right? And I sympathize with the complexity of that. Lots of stakeholders, patients often get confused around who's calling me, like who exactly needs something from me in this process. So it's not ideal by any means. So this movement towards some of the modernization elements of things, I think, is definitely warranted and welcome. And I do think it's going to move us in the direction of, having more efficient systems, having better systems in some of those elements. I think that the other thing that I will just point out is that, as we think about the delays in the system and some of those things that have been brought up, I think it's important to recognize that, like, a lot of those delays aren't necessarily at the insurer level, right? So I just want to highlight, as I look at our dashboard, that our turnaround times at Green Shield are 48 hours, meaning from the moment that the submission is received, a decision is returned 48 hours later. So where delays occur is often in getting the information from the doctor, getting all the paperwork that has to go back and forth, signatures and whatnot between the PSP and doctor. So there's definitely room for improvement at all levels that go way beyond just the insurer and what I just cited, the 48-hour turnaround times at that level. One additional thing I just want to also mention, and I think it's important to kind of recognize this or just be open and explicit about it. Dr. Lowe mentioned things like, delays and how that impacts patients getting off therapy and stuff. It's a bit disingenuous, I'll say, just because like lots and perhaps most of the patients are in fact typically started on compassionate supply. So when the prior authorization comes through and is being submitted, patient is already on therapy in many cases, many cases, meaning that they've started therapy. There's no delay per se. There's delay in reimbursement, which is different than delay in starting therapy. I understand it's not always the case, but there's a significant amount of that occurs that I think we have to just be explicit and honest about as well. I think that's it for me. I appreciate the perspective and being able to be part of this panel.
Thanks very much, Ned. Well, we have one more panelist to hear from, and then we have some questions lined up for all of you. I'd like to ask Joan. She's been waiting very patiently to be one of our panelists today. Joan, thank you so much for being here. Joan is the Vice President, Group Benefits at the Canadian Life and Health Insurance Association. As many of you know that organization, are familiar with it. In her role, Joan is responsible for analysis on industry issues, policy, strategy development, and to build consensus and concerns important to member companies. She has an important health portfolio, working with the industry, national healthcare associations, as well as with provinces and the federal government, particularly around best practices, strategy, advocacy, and sustainability. Joan herself has a long background in the benefits management and in the benefits industry, has spent time with Medavie way back when, and the NIHB. And Joan, I know that we've been talking about this for a little while, you and I, so I'm interested to have you share your thoughts with the group here today.
Great. Well, thanks very much, Denise, and thank you for inviting me here to participate. Really, as the association, as CLHA or CLIA, we work at the 30,000-foot level. So we're not processing claims, we're not doing PAs, we're not looking at systems for that necessarily. What do we do? As Denise said, we work with governments on healthcare matters, and there's been plenty of those to keep busy lately. Work on advocacy for the industry for our positions. And as Denise also said, work with members. We bring them together for discussions on best practices, anything that really essentially is non-competitive, and bring information speakers to help guide them in their business. On our role in prior authorization, I'll just start off there, and then I'll give you a few comments about the system. So in prior authorization, well, actually on all kind of standards, if you want to call it that, we really support the efforts to develop and maintain standards that digitize processes, digitize claims, digitize prior approvals, and also work with large numbers of healthcare professionals to make that happen. So as an example of what the industry has done in the past, now with this I'm going way back, we've standardized to a large degree a number of paper forms. So prior to my coming on board, we did the dental claim form, if anybody remembers that, that's very old, a hospital claim form. More recently, we've worked with physicians to make common disability forms. But again, all of this is forms, paper-based primarily. But we have also moved into electronic standards so that we do work with the Canadian Dental Association on their CDA-NET process. And one of the benefits of having the insurance, the payer industry all together, is that we can, get our concerns and our ideas for prioritization out as an industry to something like a CDA-NET, who can then prioritize, updates, changes, modifications into their system for our benefit, for our industry's benefit. So we do that with CDA-NET. We do that also with pharmacy on the pharmacy claim standard, which some of you may know as a CPHA standard. It's now moved out of CPHA and is worked on by CPHA, ourselves, CLHIA, as well as NPAC, the Neighborhood Pharmacists Association. So that's essentially what we do in the area of standards. And this isn't quite a standard, but I'm hearing discussion that this should be a standard. What I like about this prior approval system is simply that it can engage an insurer at the level that insurer is appropriate for that insurer. So if they're, just wanting the forms, that's good. If they want the whole system, that's good as well. So it's nice that can happen, that they can take baby steps into a system. As Rami had said, insurers are at all stages of development and priorities. So some may prioritize this, others may have other priorities that they need to put in place. IT systems are complicated in insurers. So I think actually, Denise, I'll just stop there and we can get into the questions.
That's great. Thanks very much, Joan. So what I'd like to do is ask all of our panelists to click on their, at least their video, and we'll get into some of the questions. I know I've got a few that have been coming through sort of all afternoon. And so I'm going to bebop around our panelists, and I'll start with one panelist, and then if one of the other of you would like to join in the discussion, then that would be great. One of the questions that we had early on in our presentations this afternoon was, where are insurers on prior authorization? Are they, looking more now towards electronic prior authorization? What kind of engagement do we have from insurers? So I don't know if John or Ned want to pick that up. You can nod or unmute yourself as to where I understand that for competitive reasons you might not be getting into any specifics, but if you can talk at a high level, that would be great. John, I see you unmuted yourself, so that's great.
Only to refer to Ned's expertise. So
so go ahead, John. Maybe you can tell, where do you think the industry is, and how far are we away from an adoption to make everybody's lives easier?
Well, my take on is that pretty much every insurer that we speak to is very keen on learning more and is very keen about, I guess, determining what the future looks like. And that's a lot different than actual movement, right? And in fact, it's that sort of that reality that made us choose a paper-based form solution first. Because one thing is going to be for sure is that for EPA to be 100% coverage, we're going to need national standards, and we're going to need a lot of big players move, and probably even legislation at some point. And if you just look at what happened in the US, they had all of those pieces in place. And, you know, it's only now that that's really starting to pick up, right? Now, of course, they started in 2008. It was a different world from a technology perspective at that point. So when we did our sort of assessment of the lay of the land over the last 2 years, we came up with the approach that a paper, you know, an electronic system that's based on the current paper forms will probably be needed for the immediate future and probably for the next 5-10 years, right? Because these forms aren't going to go away anytime soon. So I think that there's a lot of people who are talking about this and interested in it. And you know, we're just here to go along with the first movers. But ultimately, I think EPA is going, you know, when we look forward 20 years, it will be the EPA solution, something that looks and feels like what's happening in the US. Really, the only unknown is, you know, how long it actually takes to get there and what's the path that we take to get there.
Yeah, no, absolutely. Ned, would you like to make comment? What's your sense in the industry?
Yeah, I think John's right. I mean, it's not, I think public plans are certainly leading the way as it pertains to the infrastructure they're developing in Ontario and BC and other places around some of these new programs. I think the modernization at the insurer level is starting to get some traction, but I think it's definitely early days. And there's almost like two problems to solve for. There's the element of the receipt of electronic information, you know, and the inputs, like whether it's going to be a website or fillable forms or whatever. And that's the solution that OKRX has developed. So, you know, such a fantastic solution. But also just in terms of it internally at the insurer level around how to, now that you get this electronic information, you need systems and structures to be able to consume it and manage it. So things like CRMs, Salesforce, and others are good examples of the types of things that are being used to manage the information internally. So there's like two levels of reform that need to occur, and I think that's definitely an important one. I also, you know, I'll pick up on a point John said too. I think it's also really interesting, like when you look at the regulatory element of things, like there's virtually no, well, not virtually, there is no regulation of this element of in private plans, right? Like there's no nothing governing how this is conducted. If you look in the States, you know, to some degree, there's a lot more down there. Like there are rules around, you know, how an escalation must be handled. It must be a second pharmacist that must look at it, etc. So, you know, there are turnaround times and things that are measured. So there's definitely a lot more of that regulatory infrastructure around that. That just simply doesn't exist in Canada.
Yeah, no, very interesting. Yeah. Joan, would you like to make any comment or should I move on to the next point?
I'll just give the example of what happened with CDA-NET, if you're okay with that, because that's been around probably for 15, 20 years. They started off with a claim system, added on predetermination, as we call it in the dental world, attachments and a number of different innovations. That was probably 9-10 years ago, and still not every insurer has necessarily moved to that more enhanced system with predetermination. So it does take time, takes priorities. Yeah.
Yeah, and there's a lot of competing priorities, as we know. Well, I'd like to pick up on something, that Ned mentioned, and I think John, you sort of alluded to it as well, and basically what we've got right now and what our initiative is trying to do. So this is totally shameless self-promotion, but I think what we're trying to do is serve all stakeholders. And I think without that legislation that's in place right now on the paper-based system that exists for prior auth, there really is nothing for patients or PSPs or physicians to say, this claim is taking longer than normal. This is not meeting the way something should be handled. Something's going wrong here. Not pointing fingers at insurers or any one group, just something's not working. And so that's one of the things that we're going to be working on in 2023 is exploring those the opportunity to create those best practice guidelines. And I'll be on the phone to Joan or on email with her to talk about this some more. And hopefully we can have some of the payers involved in that as well, because we really do want this prior authorization initiatives that we have to be to serve multiple stakeholder needs. It's not just about one group or the other, or getting a claim paid. It's about serving every stakeholder. One of the questions that has come up from attendees is, and it's a good one. So you mentioned, Dr. Lowe, that we've got SAIDI, and then we also have a system in BC now that's an electronic prior auth system, or at least submission system on the public side. So how do we coordinate private public if we do go down that EPA route on the private side? So again, not meaning to pick on you, John, or maybe Alan wants to tackle this, or maybe both.
Go ahead, Alan.
Sure, maybe I'll start. I don't think I have the solution. It is not the $1 million question, it's probably the $1 billion question. It's very difficult, of course, to align and get all of the providers to work together. And we've seen that with EMR already. I mean, even hospitals in each of our provinces, we can speak to that. Even the hospitals have a difficult time landing on one system that's fully accessible, interoperable, and shared by all the different providers. So to try to coordinate that in a private healthcare industry through the insurance coverage, I think is going to be ultimately challenging. So the way that I see it working, and probably we're working on it now, is leading by example, to have some things in place where at least you've got maybe some of the roads built, and then somebody might build the highway that will connect them all, so that we have individual pockets that work well together, and maybe that will cause others to maybe jump on board. So if OKRX works well as a platform, and you get, let's say, 5 or 10 insurance providers work with that platform, others may feel compelled to join that one, or they might create their own, because now it becomes a competitive edge. Certainly you'd want to be serviced by a group that's well connected, that has that interoperability. You don't have to answer the question 10 different times to the 10 different providers and people that ask you things. So, competition may be a good thing, but at the same time, competition makes it so that in the healthcare field, we have EMRs all over the place that don't talk to each other, and charge us as practitioners a lot to have APIs and have communications between the different software. So we end up logging into so many different things to be able to access different pieces of information, which is very time consuming, of course. And in this time of shortage of healthcare human resources, it's not something we really have.
Yeah, absolutely. Yeah. John, did you want to make further comment?
Well, it's going to sound like a broken record, but to me, again, the solution there is eventually to have standards, and those standards, either through legislation or just through everyone agreeing, which is, as Dr. Lowe said, pretty challenging. But I don't see that contrarian to what the provinces have set up, right? So they've set up a process that receives information, and now at some point you would just, whatever the standards happen to be, they would open up their system so that people can push information as long as it complied with the standards and complied with what they needed to do. So I think ultimately, probably, and if you look at what's happening in Ontario, it's actually quite amazing. Like I don't think 5 or 10 years ago we would have thought that they would be giving information like what we see in OLIS to pharmacists and so forth. So I think they're definitely going in the right direction. I don't know if it's on their roadmap. They definitely don't tell us much about what they're thinking when it comes to the SAIDI system. But ultimately, once we have standards as a country, then we can leverage those standards across all of the payers, regardless if they're public or private.
Yeah. Okay. Thanks, John. Rachel, maybe I can turn to you. I know you wrote me a little note when we talked about benchmarking and best practices. And, I think sometimes when we talk about stakeholders, I know we're all working towards, getting patients the right therapy that they need at the right time, But, what are sort of the real pain points, and how do you think that, the initiatives that we've been talking about today can really make an improvement, and what more should we be doing?
Thanks, Denise. I think, we sort of touched on, or I tried to touch on earlier, the the capacity for an initiative like an EPA initiative to start to address some of the timeliness issues with the prior authorization. Ned, you spoke to your own internal sort of service standards, which is great. Unfortunately, that's not the case for everybody, and I think some of that comes down to how the system is set up. And are there ways we can get rid of what I like to call dumb delays? Like this idea that we've got to write something on a piece of paper and somebody's got to drive down to the office and sign it, and it's got to be faxed. Like, to me, those are dumb delays. Let's get rid of those, because that's not helpful to really anybody. So I think that the electronic prior authorization initiative has the potential to address a lot of the timeliness issues. One of the other issues is transparency. And sometimes it can be really difficult if a claim has been denied for a patient to figure out why that is. And every insurer is different with the way that they communicate that, how quickly they communicate that, and how quickly they communicate those details in particular, because that's really a jumping off point for the patient to figure out what they're going to do next. And then the third the third issue that I don't know that we can tackle through this, but I would feel remiss to not bring it up, is it's also related to transparency, and it sort of has to do with the patient voice. Public plans, with all their warts, they have a certain level of transparency as to what's expected in the service standards associated with that. They also have some process, and usually they point to CADITH for this, of incorporating patient voice and patient input and clinician input as well. So those criteria that are implemented in public plans, we know as a patient community that we've usually had an opportunity to help shape those by sharing what's going on for people on the ground who live with that specific condition and have access to the treatments that are out there. We don't have the same opportunity with private plans. Because private plans and public plans kind of have different goals, I think that there's also an opportunity, and that's perhaps an initiative maybe into late 2023, early 2024, where we could all look at tackling that together. But really the timeliness and some of that transparency, I think that the EPA initiative has a lot of potential to be addressing some of those immediate concerns for people.
And maybe, if we can create some voluntary kind of benchmark standards and engage insurers to discuss, what we should be looking at based on where we are now, what the system is right now.
Yeah.
I think
What's
that
doable.
I mean, do you think that would, and we post that on our website and get that out there so that patient groups are aware of it? And do you think
that would be really helpful? I think sometimes people are waiting and they're sort of like, I don't really know how. It feels like a long time because they're waiting for an important decision. And sometimes it's kind of, it's not that long by industry standards. And sometimes that's really going to differ. If you have a later stage melanoma, it's going to be more urgent. And that's why we have drug access navigators. That's why we have some of those patient support programs to help address those urgent situations. So I think that would be really, that would really set apart the insurers that chose to follow those benchmarks or participate in creating that in a really positive way.
Yeah, no, interesting. Thanks for your comments, Rachel. Ned, I'd like to bounce that one back to you because there's a couple of issues there. One is, I think there isn't, to bring Rachel's point, there isn't a lot of transparency in terms of, what if a claim is denied and you do understand the reason, but the doctor doesn't agree. Everybody has a process, my understanding is. All payers have a process for escalating that claims to go back and say, okay, let's do a second review. But it's really not transparent. And I suspect it's not really that consistent either from one carrier to another. As you and I talked about this in the prep for this session, most of us are aware that are working in this field that there are more specialty drugs coming to market, that those drugs that are in development are largely specialty. So this problem isn't going to go away. I mean, your sort of gold standard timeline turnaround, maybe 48 hours. For another company, it might be 3 to 5 days. And not all claims we're going to meet that gold standard for various reasons, whether it's holdups at the patient, the physician end, or at your end, just because of volume. And I think that's a big concern. So, you know, what do we do about some of these issues with respect to transparency and common standards, while still allowing, you know, insurers, or still having insurers, not allowing them, that's the wrong turn of phrase, but with insurers still have, obviously they have proprietary claim forms, proprietary criteria. I know I'm going on and on here, but you get my drift anyway, that, you know, how do we try and standardize something while still maintaining that element of having the, you know, the proprietary nature of the adjudication of these claims? That's basically my point. Sorry for going on and on.
It's a good question, Lisa. I think I get the gist of it. So I think Joan mentioned a little bit around the history of where we were able to come together in interesting ways around the dental form. And it's interesting because, like, it's a good reference point because the dental form is a dental form. It's really standard, right? Like, so it's universally understood that when you go to a dentist's office, you know exactly box 1, box 2, box 3. Having said that, that's also the fact that while dental treatments may vary, you know, the nature of the way the submission process for claims doesn't necessarily have to be vastly different. Whereas I think with drugs, it is more complicated. Some drugs have 3 questions, some drug authorization forms have 3 questions, some have 7, some have 10. And it just depends on how complex the drug is and what are the pieces of information we need to really properly assess the appropriateness of, you know, of paying that claim. But, you know, I completely agree that I think increasing transparency is going to be an important element of what we do going forward. In fact, you know, a lot of where we've been focusing over the last few years has been on that. One of, you know, many of my team members have in their title patient experience as an important element of their actually, you know, of their mandate and their job to focus on that patient experience. So things like, you know, one of the things we look at is, like, historically, whereas we might have denied a prior authorization on the basis of something missing, let's say a signature is missing, we would have just denied it and said you haven't been approved. You know, we've now gone to a place of being much more specific in saying, okay, it's been denied because signature is missing on page 3, or, you know, you haven't indicated prior therapy, or, like, we're getting much more specific around some of those elements. I understand that's just a drop in the bucket, but it's moving us towards that place that then at least you know what to do with that, right? So you're taking that and make it actionable information versus just, you know, a flat out denial. So I think it's a journey we're on. I think it's one that's going, that the digitization and the digital piece of this is going to help. And I mean, you know, think about something like as simple as drug claims. You know, now when you walk into a pharmacy, you don't think twice about the fact that you're going to present your drug card and the pharmacy is going to submit your claim to the insurer. It's going to either go through or deny, hopefully go through. But if it goes through, like, you don't think about the idea of paying, getting a receipt and submitting. Like 10 years ago, that's how you did it, right? Like you took that receipt, you put it in a, you know, a paper, you know, envelope, and you sent it to the insurer and you waited, whatever. So these systems have evolved, right? And so will this one. But it's a journey, and hopefully we'll get there faster than later.
Yeah. And what about that, you know, transparency in terms of, you know, not just in terms of denials, but in terms of what that process is, not the specific criteria, but the process. So, you know, what is a good turnaround time, and what is the process, what is a recommended process if a claim has been denied, you know, what the escalation process is that a patient can expect, because that does vary by insurer. Do you think we can come to some common benchmarks, some best practice recommendations?
I mean, that would be a great idea if it's possible to get to that place, and where it can be buy-in. You know, I look to Joan as our industry kind of representative to think through bringing those to some of our committees that we as a group, you know, participate in and talk about those. And I know that there's examples of that, I want to say, with the RA space, where some of that work has been done to standardize those forms through these kinds of committee work. So, Joan, I don't know if you want to talk about that a little bit.
Yeah, Joan, please.
I just wanted to say that there is some regulation around this, not the actual timeframes, but for instance, a complaint. So complaints and escalation process needs to be visible at every insurer's website. So you should be able to find that really easily just by searching. And then, of course, we have the Office of the Life and Health Ombudsman. which takes escalated complaints that aren't resolved at the insurer level. So there's that process as well. And then I would say that there is quite a bit of investigation by the Canadian Council of Insurance Regulators. Each year, they gather market data on turnaround times, denials, rates, and all of that sort of thing, and they publish it. So there is some transparency there, not by insurer. They publish it by, I think, province and a number of different metrics like that. So that's the point I wanted to add, is there is
Okay, good,
oversight.
very good. Yeah, no, and those are some of the things that I think I'll connect with you about, because we may add those to our website. So that's great. Well, we're almost out of time, but I wanted to kind of leave the last word with Alan out there in BC. And, based on, the last sort of 10 minutes or so of discussion that we've had, what observation would you like to make about how things are maybe different in some of the other provinces, particularly say out in BC where you have pharmacare? So to what extent does this resonate, some of the most recent discussion we've had in the panel?
So certainly all of it does resonate. We experience the same kind of issues and problems across the board, even though BC is probably the only province that you can absolutely say that everybody gets coverage, all ages, all groups. And that's not the same for all provinces across Canada. There's divvied up by age groups or by conditions and that kind of thing. So in BC, pharmacare is also the first payer. And so it does change things up a little bit on how it's done. But I think in some ways, because pharmacare is the first payer, we can look at how they're doing it and maybe learn or spin off some standards that come out of that, because it's easier for them to set standards because of the ability to process all of the claims. And we also have a PharmaNet system that's essentially the best in the world, where every prescription is logged on a database that's accessible. And that's every prescription filled in BC. And we can't say that, across the board.
Right.
But all the things that we're talking about, I think, are the issues that we continually face. I maybe want to point out something that might be leverageable, or we can leverage on, is the fact that although there are no regulations around, drug access navigators, patient support programs, and all of the groups that we've been talking about with regards to some of the work that the private health insurers do, it kind of comes down to the practitioners. The practitioners are all licensed and are highly regulated by their colleges. So I'm talking about physicians, nurses, pharmacists, and they have to abide by bylaws and rules. They're very specific rules that govern them. And, they could lose a license or have to close a practice because they don't meet certain best practices. And so I think from that point of view, we see physicians and pharmacists in different groups make decisions based on the fact of long delays and choosing drugs because of a long delay of getting somebody started. And I know Ned did make an example or made a comment before about, and I did not mean to be disingenuous at all about patients not getting on their drug, but we do see many patients who don't receive them. And yes, there's a lot of compassionate drug that is going on. But at the same time, it'll be up to the practitioners to decide on a time point to say, this is too long. We're going to switch you to another drug. We're going to do something different. And I think that's currently the lowest common denominator we're kind of dealing with. And a practitioner literally can get in trouble if they don't keep on top of this and ensure a patient gets treated. So in rheumatoid arthritis, it's particularly important because time is joint. And even the CRA guidelines have particular timeframes of when a patient needs to be seen and when disease-modifying therapy should be started. So if those regulators were to put some things in place, it will drive movement because they need to be adhered to. We can't just take a bylaw or regulation by our colleges and just take it on guidance. We have to follow. We must be 100% compliant to those.
Yeah.
And right now we don't have regulation with support programs or drug access navigators, and we have then a huge range. So if we can start to get some consistency, and maybe we start there, and other groups like CLIA and such can maybe emphasize, endorse them, or include them within their policies and procedures, maybe we start to get some standardization. So
that's a great point to leave us on. That's great. Oh, thanks very much, Dr. Lowe. And I'd like to thank our presenter, Remy Alcoli, who's still on the line, and each of our panelists today for joining us. John Leon Bruno, he's in my top right. I don't know about where he is on your screen. Dr. Lowe, Rachel Mannion, give us a wave, and Ned Poiskich, and Joan Weir, for each of you for your expertise and your experience in the industry and on this particular topic. I'd just like to remind everybody before we close that an evaluation will pop up as soon as your screen will go blank for like half a second, and then an evaluation will pop up. So if you want CE credits, you have to fill out that evaluation. If you're outside of Ontario, we will look after you. Don't worry, we'll do our best. And on the website, you have the link. You'll be getting the link in the follow-up email that we send to you. Please use it, pass it on, give us some feedback. Let us know what you think about it, how we can improve it, amend, change, whatever. We want people to use it. There's lots of downloadable PDFs for your clients if you're an advisor, and there's lots of access points for patients. Rachel, for you and your patient group associates, please use this site. We want to make sure that we can improve it and keep it going over time. So I'd like to thank everybody for being on the line today. Appreciate everybody's time, and look forward to getting together once again with the next update on prior authorization in Canada. And let's kick some butt for against the Americans, and let's do a great job here in Canada for our patients and save the mental health of our practitioners as well. So thanks again very much, everyone, and have a great afternoon.
Excellent.